Okay, so this is going to be like a really short radiological case. We have a 12-year-old boy who is brought to your hospital by his mother, and he has had a chronic long history of right leg pain, and there's swelling on examination. You inquire further, and you find out that there is no history of trauma or recent fall. In significant past medical history, on examination, you notice swelling as well as tenderness of the right lower leg. Elevated ESR and LDH readings are noted on lab evaluation. Okay, so there's a really high chance that the next thing you're going to do is order an X-ray. Over here we have a lateral view. We can appreciate the knee joint and as well as the lower limb bones, the tibia and the fibula. The tibia is looking fine. We have a really nice cortex on both sides and a medullary cavity in between. But the fibula looks a bit funny, to be exact. You can see that the bone in the mid is a bit lytic or moth-eaten or permeative. Outside you can see that there are some layerings which somehow represent an onion skin. And over here we have these perpendicular hair-like extensions or spiculations which somehow represent sun rays going perpendicular to the bone. Now these two things represent an aggressive periosteal reaction. Because of the growing tumor inside, the periosteum is proliferating like really fast and aggressively. Also, you might notice that over here the periosteum is elevated and it somewhat forms a triangle. Now, given these three and four findings, as well as the age and the demographic of our patient, the location, the diaphysis of this long bone, these are indicative of an Ewing sarcoma. Okay, so hi everyone, this is Radionomics. As discussed in the previous slides, this is going to be a topic of Ewing sarcoma, and we'll mainly focus on the radiological aspect of this tumor. Okay, so a little bit of background information. Ewing sarcoma is the second most common primary bone tumor in children. Now this usually follows osteosarcoma, which is the most common one. The usual age bracket that you would usually see in your clinic would be 10 to 20 years of age, and it's usually going to be a boy, and it's more so commonly seen in white population. Now, the reason for this is that there's a specific genetic abnormality which leads to a specific group of tumors known as the Ewing family of sarcomas, which are more so seen in this population. Talking about the pathophysiology, as I just mentioned, this is usually a chromosomal translocation on the EWSR1 gene. It's found on chromosome 22, and it's usually translocation from the chromosome 11 and 22. Some sources say that it usually arises from mesenchymal stem cells, the tumor itself, but majority agrees on the fact that the malignant tumor cells arise inside the medullary cavity and from the neuroectodermal cells. Okay, so coming down to some clinical features, it's usually more common, as discussed before, in the diaphysis of long bones, but it's also seen in flat bones, which more common so in the pelvic flat bones. Now, the patient would usually present with localized pain, which is worse at night, common for any tumor, and the child would complain of pain during bedtime. Now, you might also expect some B symptoms, including fever. Now, remember that B symptoms are usually seen in lymphomas. Now, as discussed before, there is soft tissue reactions and inflammation. So you would notice swelling of the involved part. And since the bone is really weak, it's moth-eaten, it's lytic, so you can also expect pathological fractures. Now, even though it's more common in the diphysial region, it's also seen in the metaphysial region sometimes. Now, the tumor is really aggressive, so you can expect it to metastasize really early. But the good part is that if it's localized and if you pick up early and start chemotherapy, then there's an 80% chance that by 5 years the patient would survive. Okay, so coming down to the fun part, we have an elevation of the periosteum on the X-ray as seen over here. Now this is a Codman triangle, and as you might recall, you can also see this in an osteosarcoma. Now these blue and yellow arrows point to two different types of periosteal reaction in response to the growing tumor. Where here we have perpendicular layers of the Sharpie fibers being laid down because the periosteum does not have enough time to lay down concentric layers. And as you can appreciate, they somehow resemble bursting sun rays, just like over here. And it's called a sunburst appearance. Over here we have an onion skin appearance, which is the exact opposite because the periosteum has enough time to lay down concentric layers which are parallel to the bone itself. And so these somehow resemble an onion skin layering, so that's what they're called. In the mid, you have a moth-eaten appearance or lytic appearance of the bone because of the destructive nature of this malignant tumor. So usually this tumor is picked up on x-rays, but sometimes if it's inconclusive or if more evidence needs to be established, then the patient may go on to have an MRI because they're more detailed. But usually the MRI findings endorse the findings of an x-ray. You have a permeative lesion inside of the medulla. You have destruction of the cortex because the tumor is expanding, and also you have a periosteal reaction in response to the tumor. And again, as mentioned, as discussed before, there's inflammation, there's edema in the soft tissue, so you will see soft tissue involvement too. Now, the big point to pick up in this case is that this tumor, an Ewing sarcoma, is usually hypointense on T1, unless the T1 is fat saturated, but usually it's more hyperintense on T2. And so you'll see a really bright signal when you do the T2 MRI. Okay, so as talked about in the last slide, you have a T1 over here and the T2 over here. By the way, this is a different case. The patient had an Ewing sarcoma of the humeral head in this patient. So as you can see on T1, the tumor is over here. You can see some bone destruction, a tumor originating inside the medulla. But what you can also notice is that it's not that much prominent. It's hypointense in this case, as you can see over here as well. But on the T2, on the right-hand side, you can see that there is significant proliferation of the soft tissue and destruction of the cortex and the tumor originating inside the medulla. And since it's really hyperintense, that's how the T2 is really significant in picking up this tumor on MRIs. Lastly, the patient may go on to have another scan, in this case a bone scan. And the whole principle of a bone scan is that it usually the signal or the radionucleotide usually concentrates and then gives off emission at the tumor focus. So in this case, we have a really high signal coming off from this focus and this side. And on the anterior scan picture, we have on this side. And this comes off as the right humeral head Ewing sarcoma. Thank you so much for watching and stay tuned for more.